Okay, thank you very much. Let's move on then to paper 9, which is the update on equality and health inequalities. Ian, over to you.
Thank you very much, Chair. This profoundly important item speaks to our moral responsibilities to improve and equalise the life chances of all of our citizens, as well as our narrower specific statutory duties under Section 7 to tackle inequalities in access to healthcare and outcomes of healthcare. Looking back, in 2013, the board agreed 9 deliverables, and the paper reports progress. The wider context is that by international standards, England continues to perform relatively well on equity, as evidenced, for example, by the Commonwealth Fund. And I can report positive progress in reducing the gap in cancer mortality, in infant mortality, the progress in launching the Workforce Race Equality Standard across the NHS from April of this year, and the associated delivery programme under the leadership of Yvonne Coghill and Roger Klein, re-establishing the National Equality and Diversity Council as a driving force and oversight body, and moving rapidly to fairer funding for CCGs through the board's allocation policy. However, a vast amount remains to be done. For example, in reducing the gap in life expectancy and healthy life expectancy, in tackling the twofold variation by CCG in the variable distribution of GP practices, in transforming care for people with learning disabilities, as Jane has been describing earlier today, and achieving parity of esteem for people with mental health problems, for example, in reducing the very large and unacceptable life expectancy gap for people who suffer from psychosis. This calls for NHS England to embed the progression of equality and tackling of inequality as an integral part of all of our programmes, for this to be part of our DNA, for us to be driving change through our specific clinical priority programmes, as well as wider system change endeavours such as the new care models work, and there is interesting work that the Institute of Health Equity, under the leadership of Sir Michael Marmot, is taking forward with a number of our vanguard sites, as well as providing ever clearer emphasis in NHS planning, guidance and associated support, and our dialogue and assessment of clinical commissioning groups. I invite the board to note our progress and also the challenge in this profoundly complicated and difficult area, and the work in train. Thank you, Chair.
Thank you, Ian. Let me open it up now for discussion with the board. Who would like to kick off? Margaret?
Number of different points, I'm afraid, so can you bear with me? The first one is the basic workforce question. I noticed that when you're talking about the RES standards, as you call them, workforce race equality standards, you focus on representation quite a bit, which is sound, but representation without inclusivity doesn't go anywhere. In fact, there are studies that say that people brought on for purely box ticking reasons are almost doomed to fail. So do you have standards, do you have measures for encouraging and fostering inclusivity? And if you don't, is that something that can be focused upon? That's one question.
The answer is yes. So there are 8 standards in the RES, and standards 5 to 8 relate to staff engagement scores, precisely tackling the issue you raised, Margaret.
Just on that, did you want to come in, Victor?
No, just to say that, to be honest, I'm actually pleased to see the RES incorporated in this report. because you're absolutely right, it does have measures embedded in it, but it is a key driver to improved patient care for everyone. This isn't about race, this is about improving patient care, and that's the link has been made through the res work. So I'm pleased to see it embedded is in business as usual, part of the contractual commitment. I have to say it's been a real struggle to get this far, and so well done for getting this far. There's been huge resistance to delivering it. If I may I make some other further comments? I note, and I agree with the moral imperative, but I just wanted to make the point that we often miss the connection between health equality and inequalities and demand. So I'd be interested to see a more direct connection between a failure to deliver this stuff, which is moral and immoral, and actually the reality, which is that if we don't, we're going to drive up demand, A&E, hospital, all that stuff, and for me that's the critical factor, particularly given the pressures we're under. So there's something about embedding this into the core business and the issue of demand being a driver, a reason for it, as opposed to it being something that we'd love to do if we were all moral. And of course we all are, but that's one of the risks that we take. I think the 10-year gap is an interesting, it's our mandate measure, and I'm just interested in whether we could have more on whether we're closing or opening the gap as a key metric. It's a litmus test, isn't it? We either are or we aren't, and it'd be just interesting to know where we are on that a bit more. I think that's it. I mean, I'm always saying this, but the future is decided by the things that we don't discuss. So it's really good that we've had this presented to us. What I guess I'd like to see is it embedded in our core business. It's not a moral luxury; it's a business imperative.
Would you care to respond?
I would. My take is that it increasingly is, and the paper partly reflects that the work on mental health, the work on learning disability, the work on cancer, the work on system transformation. I think the second point you make, Victor, about the demand side is one that we should reflect on further. Is there a way where we can speak more directly to finance colleagues about the contribution that tackling inequalities and equality can make towards the bottom line? I think is a really interesting question that is worthy of further exploration. And on the overall metrics, my understanding of the data is that there has in the last 5 years been a very marginal reduction in the inequality gap on healthy life expectancy. I think it's healthy life expectancy rather than life expectancy, but that the numbers look broadly static now. So this is remains very challenging.
I'd just like to build on the same point that Victor was making, because I think that this is an absolutely critical part of our sort of future prevention agenda. And there's some of this that's linked to housing, to deprivation, to all of the other factors we know. But I just wonder, and I'd be intrigued to hear more about the extent to which we're thinking about reducing inequality as a key design principle in the vanguards and how that's being taken forward.
So the short answer is that it is at the forefront of most of the local health systems who know their local communities and the demand drivers that Victor was talking about. So we have some examples of good practice, and I mentioned one of our foremost institutions who've got a strong academic reputation in analysing inequalities, the Institute of Health Equity, which Malcolm you will know very well from your previous role, is working closely with a number of Vanguard sites on what international evidence and best practice can tell us local systems could be doing to make further and faster progress in this area. Your point about prevention and driving better health, I think, is also very well made. The forward view is about the triple aim. The first of those is better health and well-being for the whole population. We will only tackle that through a combination of specific national and local measures aimed at risk factors, as well as patient activation and community engagement. If I can just take an example, the first of those, smoking and smoking cessation programs, we are working closely with PHE on what we need to do, because the history of smoking cessation in the last 15 years has been of success in reducing the numbers, but that success has been primarily effective with middle-class smokers, and we've actually got a relative increase in terms of the inequality. We now need, in order not just to tackle demand, but also to improve mortality rates, as shown in the Cancer Task Force report, to think of what are the new and additional strategies nationally and locally to make improvements in smoking. And if I can just tie it back to a specific Vanguard, the Filed Coast multi-specialty community provider, which is in the CCG where Amanda Doyle is the clinical chair, has one of the worst smoking in pregnancy rates in the entire country, and that is an area of local focus and action.
Okay. Barbara?
Just one comment, really. In the 40-odd years I've worked in the NHS, I don't believe I've ever met a single person who hasn't really felt very committed to this agenda. I think people really, honestly and truly do want to make a huge difference. But it is very difficult. I was going to reiterate what Ian said. Every time we find something that improves people's health or their well-being or is better for the health service, it's always that it's not the disadvantaged who take it up, and therefore that tends to always fight in the rising tide of increasing inequality. So as I say, I think there's no shortage of commitment within the NHS, but I do think people out there on the front line need as much help as they can with every trick in the book as to how they actually affect this. And I think we need to remember the huge role within delivered services in the NHS. There's obviously a major role for the broader determinants. There's obviously a major role for public health in improving services, but a lot of what can be delivered is about the way we deliver services.
Can I just illustrate that with an example? Because I think, so, there, if I may use a turning point example, an individual, I've used this example before, but I think it illustrates the issue quite clearly. An individual arrives at a substance misuse service with a cough. He's got a substance misuse challenge that he's had for 20 years, and a GP, a clinician, fully qualified, sees this individual and can work with their substance misuse challenge, but cannot prescribe the necessary antibiotics to deal with their chest. Sends the individual to their GP. The chances of getting to their GP is about 2%, which means they won't get to their GP. The chest infection will get worse, which means that person will go to A&E. In one area, that's 2,000 people with similar issues. Resolution is directly connected to the way in which we commission services. So my point is that we could make changes that would reduce demand, and actually we're talking about the same people. He's smoking, taking drugs, drinking too much. His kids are obese because there isn't a family framework. So there's something about the cohort that we work with first in order to reduce the demand. There's a tendency to work with the people that are easier to get at. We apply the solution, we reduce their use of smoking, whatever, and we forget the people that actually will drive the demand next. It's doable.
I think I've actually just building on Victor's point, but in fact, I really wanted to know that we were focusing on specialist organisations, whether in the third sector, who can go out to the hard-to-reach 11 million, because there's such a huge number of people, and expressly give them the not just the tools, but the support, the continuing support. And it is a cost at the front end, but as Victor says, it really does have a massive impact on the bottom line. So that was my first point, is whether we are actually going to that sector and actually making a provision to enable them to be able to provide for the 11 million. And then my next point was about the integration of healthcare for the military, because of course, in the same way as the health and justice agenda needs to be properly rounded, so similarly, so does the provision for the military, and you don't mention that.
On your first point, going back to Tim's reminder of the forward view topology, chapter 2, we've said to drive better health and well-being for the whole population, we need to get serious about prevention. We need to be engaging and activating patients, and we need to be engaging communities far more effectively. On that last point of how do we engage communities, we have a programme of work which is led within Tim's directorate, now under the directorship of Anu Singh, which is precisely about doing that. We have many examples of great practice. Social prescribing, for example, there are exemplars around the country in Tower Hamlets, in Rotherham, Bassetlaw, and many other places. And the forward view articulated the huge opportunity that exists to build on the connections that we could be making with our third sector partners in order to reach groups that may not be traditionally wanting to use NHS services. And within the planning guidance and then the way in which we engage CCGs, we have a fantastic opportunity to do that much more systematically. We also have an opportunity through the rollout of personal health budgets and integrated personal commissioning, which is all about person-centred care, to engage the voluntary sector as partners in designing patient-centred services, building on the excellent work that National Voices have done with their segmented approach to I statements, what matters to the person in different service lines. On services and integration with military, health and veterans, I'm afraid I'm not an expert on that specific area. I don't know whether Barbara, you wanted to come in on the integration with medical defence services at all, or if not, Margaret, then we should certainly pick up further and get back to you.
Thank you very much.
Not to add anything very specific, just that this is high on the agenda for the team that do both health and justice and military. Because in both those instances we've got people who specific groups that we need to reach. I mean, it's often easier to reach some of the areas through military, but one of the biggest issues is often those people who've left the service and who have problems there afterwards. But it is part of the work programme.
Thank you.
Right. Okay. John.
Could I just raise the issue of specialised care? Really a comment. Obviously, I'm professionally involved in people with rare disorders, and Lord Walton pointed out when he compared muscular dystrophy care from the northeast to the southwest, there was almost twofold difference in life expectancy because it was an area of interest in the northeast and not in the southwest. So the opening comment in section 320 that we're making good progress on understanding the standard of care across the country. There are some 7,000 rare diseases of that sort, and We've now got a rare disease forum, and I'm chairing a specialist subgroup, task and finish group, on registries and databases, so that we can think with Public Health England about how we can develop pseudonymised databases that can actually find out who have these rare diseases, and particularly the ultra-rare diseases where there might only be 100 people in the country. It's really the ones who shout loudest who get noticed, but the ones who don't have a voice get ignored, and very often their standard of care is appalling for the simple reason that no one in their immediate vicinity has any idea what's wrong with them and how to care for them. So really just to say that in that capacity as chair of that rare disease task and finish group, I'd quite like to interact with Ian about how NHS England engages in that process, because as Liam Donaldson showed, 1 in 17 people has a rare disease, so it's actually a fairly big chunk of our work, and they are scattered and almost certainly not getting equity of care because of that.
I think we've had a very good review of this paper. I think, Ian, you have a demonstration of the commitment of the board to this as an agenda. There are several levels at which we need to pursue it. I'm always taken by the rather crude characterization by Don Berwick in terms of contribution to health. It's a 50-40-10 rule, in which 50% is genes, 40% is life, style and living experience, and 10% is formal health care. That rather crudely puts the set of relationships in place, and I think causes us to reflect on the trends of inequalities in income and social inequality in society, for which the NHS cannot wholly provide the patch and repair necessity. And yet I'm very taken with the comments both of John and Victor in particular this morning of where the NHS falls short of dealing with very vulnerable communities who are the victims of the, if you like, the social determinants of health. I think having reviewed the paper this morning, it's something we wish to continue to work very hard on. I think there's an enormous amount of work here to do. It's not just the statutory obligation that we have, but I think the fundamental concept of a comprehensive healthcare system, which provides services to an entire population, means that this has to be a particularly high priority for us. So thank you for the paper, and I think we're very happy to endorse the programme of work that's underway, and I think we've given you a few steers on the directions of travel the board would like to see developed. Okay?